So I'm going to move on to our next speaker, which is Carlos Luna from Buenos Aires, and he's going to be discussing the use of aerosolized antibiotics for VAP.
Well, thank you very much. Thank you very much, Mike, and thanks for this invitation to speak for AIM that is supported also by me. This is a group of. This is like that something happened more than 20 years ago, and we're still talking together about ventilator-associated pneumonia. At that time, we were interested in the diagnosis and in the use of appropriate therapy, and now we know that we will not have antibiotics soon, and this is now our concern. Well, this is my financial disclosure, and well, I will speak about the aerosolized antibiotics. And the story of aerosolized antibiotic is older than us. This happened more than 40 years older than us as speakers, at least. 40 years ago, we could find papers talking about the local installation of antibiotic in people in the ICU. And they were looking not exactly on infection or colonization, but there were a lot of studies made at that time. About in the 90s, they appeared some studies made with nebulizing antimicrobial, but nebulized not with the newer nebulizer, but by the usual nebulizer used, for example, for the administration of bronchodilators. The problem with the antibiotics, with the susceptibility, with the high levels of resistance, had reborn the interest on the nebulized antibiotics, but there are some considerations that have to be taken into account, because these nebulized antibiotics is the pharmacokinetic, pharmacodynamic, and the importance of this is different that what happened with the nebulization of bronchodilators, for example, in asthma or in COPD, where this way to administer the therapies is usual. For antibiotics, it is necessary to know the precise dose necessary to balance efficacy and side effects. The cost of the drugs is much higher, and what is very important is that we have to minimize the environmental exposure of with this drug, because it's harmful for everybody where the patient are. This is from 10 years ago, when this paper was written, as the different brands of manufacturers for the different nebulizers, and this is because there was Hess et al. Did a study evaluating how was the efficacy of the nebulizer to give an output of the drug, and how much of this drug was available in the airway of the patient. And we can see that there is a big difference in the output of the nebulizer, and how much is available with the different trademarks of nebulizer. So this is one of the things important, and the other thing is the difference between the different nebulizers. So the nebulizer must be able to produce a very small particle, approximately 7 to 5 microns, and to be able to achieve the alveoli, that is where the pneumonia is and where need to achieve. There are several issues that have to be taken into account related to the ventilator, the mode, and how is the different issues on the ventilator, related to the device used to provide antibiotic is not the same metered dose than nebulizer. The issues about the drug, the dose, the size of the particle, the duration of the action, related with the ventilator, with the circuit, with the endotracheal tube, and the gas humidity and density. Also related with the patient, with the severity of obstruction, with mechanics of airway obstruction, and presence of organic or the dynamic hyperinflation, and the synchrony. So, but there is a lot of issues for all of you now about the severity of HAP and VAP, particularly VAP, that is a disease that have a high mortality and a high attributable mortality also. And the gram-negative pathogens, particularly the multi-drug resistant pathogens, account of 65% or more of the cases of pneumonia in the intensive care. And the fact that also that the aminoglycosides are suitable. The problem is that when administered intravenously, they have not very good PK and PD. So the administration of this therapy by nebulizations could achieve, yes, very high concentration and very useful for therapy. So we require a treatment with antibiotic pneumonia at high concentrations in the lung where they have to act. And there are issues with toxicity also, and this could be achieved by nebulization without producing high levels of antibiotics in blood. Let me see, go on. There have been a lot of research about this before applying in the humans, and one of the way to analyze this was the piglets model developed by the people in France, by Charles Hugo Marquet and Ruby and so on. And they more than 10 years ago, also 15 years ago, they developed or they participated in the development of this new model of nebulizer that act using a piezoelectric transducer and vibrating waves, and a huge number of vibrations per second, something like 100,000 of cycles per second, as make the very small particles of adequate and they have no air added to the system, so very convenient to obtain a very good concentration of the antibiotic in the inhaled air in the during the mechanical ventilation. And the concentrations that are achieved in the lung tissue in the piglets that were inoculated with pathogens, gram negatives, is very high. Here you can see what is the concentration obtained in the lung tissue, and this is in the concentration obtained in the lung tissue when is given by intravenous as usual. And this is 5 microgram per gram, and this is 180, so is about 20 or 30 or 40 times more than which is the concentration obtained given by intravenously. And the same happen, depends if the pneumonia is severe, the air that achieve the lungs is less, so it's not so good, but the concentration even here is 10 times more than they obtained by intravenous administration. So this makes that the antibiotic administered in this way are very highly available in the lung. This this group and other groups studied different antibiotic, and the result was more or less the same. This is another study made for by the same group. I have been there and I took this photograph. This was in 2002, 15 years ago, and they were working at that time with ceftazidime. But again, this system may be very closer to avoid the contamination of the air where everybody of us were, and this is one more of the difficulties to obtain this kind of nebulizations. And again, intravenous administration achieve a concentration here very small, was higher with the nebulization, and if the nebulization was done with the nebulization with helium, because of the lower viscosity was a little higher too. This was in the study by ceftazidime. Again, more or less the same of the other figures is in another study by Gorsen of the same group, looking at which was the micrograms per gram after in the autopsy of the pigs, the concentration of the antibiotics when was given by aerosol versus intravenously in different lung segments. And here, interestingly, in the piglets that are ventilated in a prone position, the concentration is lower than in the rest of the lung, but again, the concentration is several times more than the concentration that is achieved when it's administered by intravenous way. Again, the comparison, we have seen this slide before, and this is the efficiency of the deposition and healthy piglets and inoculated. The inoculation made the appearance of pneumonia reduce, but not so much the concentration in the lung in the autopsy, but again is much more higher than the concentration obtained when it's given by intravenous. Here we can see when this is the blood concentration when it's administered in the closed circles when it's administered intravenously, and this is the blood concentration when it's administered. This is nebulized intravenously, and we know that as is expected, the blood concentration is less than half in the peak of the concentration, but then obtain a higher concentration than when it's administered by intravenous. That is in the blood concentration. And they observed and obtained several conclusions about the lung concentration of amikacin, between 3 and 30 times higher than the obtained when it's administered intravenously. What I said is that the antibiotic deposition in the infected lung and the bacterial efficiency were better with the nebulization than when it's administered intravenously, but have to say to keep in mind that the presence of pneumonia make to attain a lower concentration even using nebulization. The PDDS is nebulating vibrating mesh nebulizer that is estimated that deliver 45% of the administered dose to the lungs, and has other properties. The size of the droplets is 3 to 5 microns, and the controller of the nebulizer makes that the aerosol is delivered only during the first 75% of the inspiratory phase, making that the amount of antibiotic nebulized is about 45% of the total, much more than with any other kind of nebulizer. This is the PDDS nebulizer. This was used in a study of the pharmacokinetics that by the group of Jean and Louis et al. Was published some years ago, and they observed that the PDDS, the aerosolized amikacin, with a very high amikacin concentration in the epithelial lining fluid, and safe serum amikacin concentrations. Here we can see the amikacin concentration in the different areas, and in this other study that was published in Intensive Care Medicine, was a multi-center randomized placebo control. Mike Niederman was the first author, and they made the randomization of 69% who received standard antibiotic therapy plus the amikacin nebulizer, and the one received placebo, the other one received placebo in one of the doses, and the other one received 2 times a day the nebulization with 400 milligrams of amikacin. And the primary point was the tracheal aspirate amikacin maximum concentration more than 6,400 micrograms per ml, and the ratio of area under the aspirate concentration curve more or the same as 100 on one day, on the first day. This is from other study, but looking at what is the difference of we have seen this slide previously. The mean amikacin plasma concentration when it administered by aerosol, that the closet and intravenously, and another study that was published by Niederman was presented in the EC7 in 2007, observed the difference what happened when the patient received the nebulized amikacin in different doses, and they observed that the number of antibiotic used by the end of the therapy was less with the twice a day amikacin compared with the once a day, and compared with no amikacin received as in any time. There is another study that recently finished that was a comparison of the use of aerosolized amikacin plus fosfomycin delivered via a flow inline nebulizer, also a vibrating nebulizer. Is a phase 1 study evaluating the PK and safety tolerability of amikacin fosfomycin using a vibrating plate nebulizer. And in this study, the 9 patients in this precise study, they looked at just the use of different doses, and what they observed at the day 3, when they received 2 blinded randomized treatments, amikacin fosfomycin and a placebo, what they observed is that there was a high tracheal aspirate concentrations of amikacin and fosfomycin, and the airway clearance was rapid, and no adverse respiratory effects were noted. So the administration of nebulizing antibiotics is one of the ways that we can try to fight against the infections that are so resistant to antibiotic, and this high concentration obtained with the nebulization is one of the ways that is used trying to have success in this fight against the resistance. This is the nebulation used by Montgomery et al. Summary is inhaled antibiotic as adjunct to systemic antibiotic show promise. Aerosol delivery to ventilated patients is associated with high drug losses, poor reproducibility, and deliver a low have a low delivery efficiency. But vibrating mesh nebulizer for specially formulated antibiotics yield high local concentration and rapid clearance and low systemic exposure. It is necessary to do large multi-center trials, but to determine if this would be translated in improved clinical activity and decrease of microbial resistance in BAP patients. And well, it is needed to develop and optimize the use of aerosolized antibiotic. Thank you.